My topic is Phaco with the Pterygium in a single step. Why this combined procedure? So we all know UV exposure is a common etiological factor for both pterygium and cataract. The simultaneous occurrence of which is not uncommon, especially in tropical countries like India. Simultaneous procedure is usually preferred by the patients as it results in rapid visual improvement and lesser number of hospital visits and patient convenience and lower cost of surgery. So, pterygium will cause with-the-rule astigmatism. Again, the induced astigmatism depends on the length, width, and the depth of the pterygium extending onto the cornea. And more corneal involvement, more is the induced astigmatism. There is significant astigmatism if the pterygium extends more than 45% of the distance between limbus and the visual axis. Pterygium excision decreases astigmatism, it's improved. And once you remove the pterygium, the horizontal curvature increases and vertical curvature decreases. One more point is, as the head of the pterygium approaches the apex of the cornea, a tear meniscus develops between the corneal apex and the elevated pterygium, causing an apparent flattening of normal corneal curvature, which can lead to overestimation of IOL power. So we published our results in International Journal of Ophthalmology. The visual and refractive outcomes following simultaneous phacoemulsification and pterygium excision with conjunctival autograft, where we included 508 cases over a period of 6 years. And phacoemulsification was done through 2.2 to 2.8 millimeter incision. A foldable lens was implanted, and conjunctival autografting was done using tissue glue. Grading of pterygium. The pterygium were graded according to the extent of involvement, and it's our own grading system, which was published in ISO 2017. Grade 1 and grade 2 pterygiums were included in our study. Grade 1 is nothing but the pterygium which causes the limbus, and grade 2 is midway between limbus and pupil. So we included all primary pterygium. We have not included any recurrent pterygium, and grade 1, grade 2 pterygium. Double pterygium also we have included, and temporal pterygium were included. First we went ahead with the cataract surgery, and once the cataract surgery is done, I usually inject air bubble into the anterior chamber so that the anterior chamber won't collapse easily while manipulating the pterygium. And a thin graft was taken. Usually prefer a superior donor site, and the graft was fixed using a tissue adhesive glue in all the patients. And temporal incision was done in a nasal pterygium, and superior incision was done in temporal pterygia patients. 98% of our patients improved, had best corrected visual acuity of 612 or better. And astigmatism, the postoperative astigmatism when compared to preoperative astigmatism, we found that there was a significant drop in higher astigmatism, that is from 1.25 diopter to 2 diopter astigmatism, from close to 49% to 19.29%, that is almost 30% drop in the higher astigmatism, and a significant increase in the number of cases which had nil astigmatism. So 9.45% of our patients had nil astigmatism before the surgery, and it went up to 31.49%. And spherical error, coming to the postoperative spherical error, 65.5% of the patients had no spherical error post-operatively, and close to 30%, that is 20%, 19% of the patients had spherical myopic error of 0.75 diopters or less. So this is actually a very good result. If you choose a good case, if you choose a grade 1, grade 2 pterygium along with cataract, definitely you can achieve good outcome. And we have compared a study with another similar study, which is actually a small number study. They have included 60 cases, but ours was a large study for a longer duration. And our mean manifest refraction astigmatism was 0.73 diopters, and theirs was 1 diopter. To conclude, cataract and pterygium, they share a same etiology, so tends to coexist. Pterygium induces the with the rule astigmatism commonly. More the corneal involvement, more is the induced astigmatism, and significant astigmatism develops if the pterygium occupies more than 45% of the distance between limbus and visual axis. Combined procedure actually cuts down surgical cost to the patient, and it reduces slightly undercutting the IOL power in patients with concurrent pterygium can optimize the visual outcome and avoid any intraoperative correction of preoperative refractive error. It's an important point. Just before proceeding for a combined procedure is to avoid any intraoperative correction of preoperative cylindrical error. This is due to the fact that the exact pre-existing astigmatism cannot be distinguished from the astigmatism induced by the pterygium itself. Thank you.
Thank you, Shreesh, for that excellent comprehensive presentation. Truly, you have a great experience. Can you stop sharing the screen?
Yes.
Rishi, would you like to comment on this? I know you're a competent cornea surgeon. Would your approach be similar?
Yeah, so for some of the more extensive pterygiums, I think I would like to do them separately because, you know, many of these pterygia, after you remove the pterygium, it's not like the cornea becomes regular. You'll always have a little bit of residual astigmatism, and you can take care of that with the toric IOL. And of course, I would do the cataract surgery at least after 3 months because the corneal shape keeps changing till about 3 months. So otherwise, this approach is wonderful, and each person has their own approach to pterygium, but these are beautiful videos. The other thing is IOL calculation. Again, it can become a little inaccurate if you have the case cannot be very accurately calculated in many of these cases. So I can see Dr. Avikar nodding there. So you can go wrong with the IOL calculation. So if you want a spot on result, then it may be a good idea to do them separately. But yes, I understand the practical problems of, you know, patients coming for 2 surgeries, and sometimes we have to take this decision, especially if it's an old patient who can't have 2 surgeries. Yeah.
Whether it's with the rule astigmatism or against the rule astigmatism, or what is the difference in the cylindrical power between the 2 eyes? Will it make a difference, Dr. Jeevan, in your approach?
I think if you have a patient has a pterygium, what we showed about grade 1 and 2, and patient normally would have with the rule astigmatism in these cases, and incision would be also contributing into, you know, increasing the with the rule astigmatism in such cases. So apart from looking into amount of toricity which is there in these cases and what is the post-op outcome in these cases, if he has with the rule astigmatism of around 0.5 to 0.75, that will be beneficial to patient as such in terms of increasing the near stereopsis for these patients, and that's a good thing for these cases. But I think what Rishi talked about is also very important, especially those cases where you are looking for a toric implantation or a multifocal or a premium IOS. There I think that pterygium, even grade 1, has to be dealt first, then see how good is your cornea and plan subsequently. And I also do a lot of combined surgery because sometimes you do have a situation like that. The only issue in such cases would be to see the post-op ocular surface in this case. Because they do have more chances of ocular surface disorder. So that has to be taken care of very nicely. The defect which may be in the corneal side, and it will take some time to heal. And if you bombard with a steroid in these cases, they can develop PED or sometimes melting also. Delent formation is very, very common after pterygium surgery. And if you don't deal with the Delon properly, the entire cornea can be melted at that area. And that's a very critical point in combined surgeries with pterygium or any other ocular surface surgery with cataract.
Can I come in?
Yes.
No, like, it's actually definitely it's controversial. It's actually all in the mindset. The patients, if they are convinced about the outcome, if they are told about minimal astigmatism or residual error, definitely they can accept. If in indicated cases like grade 1 and grade 2 cases, definitely you can combine it. Where patients having glaucoma, we combine Phaco with the trabeculectomy, and patients having corneal diseases, we combine it with DSEC or triple procedure we do. And even in a patient undergoing multifocal IOLs, the expectation is too high, but even then we won't promise 100% vision in those patients. So if the patient is willing for undergoing combined procedure, if the patient understands the outcome, definitely we can plan this and do it together.
Excellent. I think shall we summarize if economics and convenience is a consideration, major consideration, then maybe combined surgery will be the way to go. But refractive accuracy and premium intraocular lenses is what we are talking about. Maybe splitting it in two phases would be a good way to go.
I think that's correct. A patient going for a premium IOL, then the money part is a secondary in these cases. It is the outcome which is more important in such cases. I would rather do a sequential surgery for these cases rather than doing combined. If patient comes for a monofocal lens and they accept using glasses, then we are pretty safe. Whatever residual refractive error, patient will accept that.
See, it all depends. Just to hello.
Yes, sir. Yes.
It all depends on what class are you looking at. In fact, I really like it. It's a different take on a combined, cataract and pterygium. Very often, it's a normal teaching that you do them separately. But come to think of it, there's a major population in our country who would really be happy with, doing it combined. As long as the pterygium is not significant. But very often you may find a pterygium which is not giving you a lot of astigmatism. And anyway, that patient is good for a monofocal. He is not a premium IOL class. So I think this is a beautiful take where, most of the patients, belong to this class. And for them and for surgeons, this is a new way to go about. I'm sure most of them must be going, but at least I wasn't. But I think it's a new take and a good take. Well done.
I have a question. Sometimes we see some patients coming in for a premium IOL, either a toric or a multifocal, and they've either been operated previously for a pterygium with some residue or a fibrotic or a regress pterygium. So how do you kind of manage it? I mean, the pterygium itself is not focused, it's not bothering the patient. But then when you want to do a premium IOL, then you need to optimize the ocular surface before biometry. So this is a question which is always there.
I think if your topography is fairly regular in the center, it should be okay, sir.
Yeah, but the tear film will be kind of abnormal, even with a fibrotic pterygium or a regressive pterygium, and that can kind of throw things off. Because a placido reflection will not really give you, it's influenced by the tear film. So that's again, it can make it unpredictable.
Tear film consideration is definitely there, but as Rishi said, the topography centrally is quite normal, you would consider. And I think in a scar pterygium, which is left behind a scar, the astigmatism which is left behind is likely to be stable. So you might not be doing a mistake by going ahead with the toricity that's measured and putting in an intraocular lens. I think
just to add, sorry.
Go ahead.
Just a quick point. Patients who have high with-the-rule astigmatism with the pterygium, the one thing which we have to think of is not just the astigmatism, but even the spherical power will change after pterygium excision. So that is one major consideration. So if the patient has very low astigmatism, grade 1 to 2, pterygium very much in the periphery, yes, possibly a combined surgery with a monofocal lens is fine. But any significant with-the-rule astigmatism is it's also a spherical error which will come into play. And even for the lower astigmatism pterygia,
one point which has already been written in previously published literature also is to aim for a low grade of myopia, because there is always a certain steepening of the central keratometry which happens after pterygium excision, even in grade 1 to 2 pterygium.
So, Suhas, I think another thing is that if the pterygium actually needs to be taken out, then you would divide them into 2 stages. If it can be left behind and still you are operating, you can do as a combined surgery.
Yes.